Neoplasia, neoplasms. Talking about neoplasia, we want to first differentiate between benign and malignant. Oftentimes, when we're talking about exam questions, this is going to get us a 50-50 shot towards the right answer, just knowing whether or not the answer choices are benign or malignant. Benign tumors and malignant tumors have very, very different features. Benign, you tend to not have as many serious symptoms with benign tumors, whereas malignant, that starts to throw up those red flags. So with these, we want to make sure that we understand which is which, because at the end of the day, a really, really good testing strategy is to try and always narrow your choices down to a 50-50 shot. When it comes to the chiropractic board exams, you need a 48% to pass. So theoretically, if you could narrow every single question down to a 50-50 shot, you will pass the exam. So starting with the benign tumors, we have adenomas. This is our glandular tissue. A fibroma or myoma, kind of connected there. This is a connective tissue tumor or some type of gel-like or myxomatous tissue, so a gel-like substance in the connective tissues. You can AKA fibroids. You can see just a couple of different AKAs in there. It all means the same thing. Lipoma, uncommonly asked, that's a fatty tumor. Lymphoma, these are the one funky ones where they can technically be benign or they can be malignant, so we need to pay attention specifically to those ones. Neuroma, this is a benign tumor of the nervous tissue. Still causes problems because the nerves are typically through small little channels so that they can cause some disruption throughout there. On the malignant side of things, we have a carcinoma. This is a cancer of epithelial tissue that can be spread through the lymphatic system. Again, the lymphoma, a cancer of the lymph nodes. And then sarcoma is a cancer of connective tissue, typically spread by the vascular system. So we can kind of compare these two. So we think of the lung, for example. Lung tissue tends to be epithelial tissue. Epithelial tissue is going to be a carcinoma. So whenever we have a question talking about a specific tissue that's more epithelial tissue than it is connective, lean towards carcinoma as an answer. When it's connective tissue, muscle, bone, ligaments, tendons, blood, all that sort of stuff, we can lean towards sarcoma. There are a ton of different conditions when we talk about all of these different types of neoplasms. So I'm really going to, and honestly, any and all of these are fair game. I'm going to primarily focus on the ones that are highlighted, as well as a lot of these, the specific ones that talk about the bone ones, we're going to see again further on down the road because obviously boards likes to test on bones because we are chiropractors. So we'll start up here with adenomas. Remember, adenomas are our glandular tissue. So we think adrenal adenoma, adrenal glands. Well, again, we'll talk more about the adrenal glands, the specific pathology for them later on. This is a benign tumor of the adrenal cortex. Oftentimes it can be functional. When we talk about a tumor being functional, that means that it is still doing the job that it's supposed to be doing. So in the context of the adrenal cortex, we essentially get a tumor, so a growth of the adrenal cortex. The adrenal cortex is responsible for releasing cortisol, aldosterone, androgen hormone, all that kind of stuff. And so we end up with excess cells producing those things. So we get excess cortisol, which turns into Cushing's disease. We get excess aldosterone, which becomes Conn's syndrome. Both of those things we'll talk about later on down the road. Fibroadenoma of the breast. This is both a fibroma and an adenoma. This is the most common breast tumor. We said fibroma can also be fibroids. So breast fibroids, very, very common condition. Pancreatic adenoma. Again, we think about what does the pancreas do. This is why the base knowledge is super important. Understand, okay, what is the pancreas? What is its function? The pancreas's main function is to do insulin and glucagon. So those two things, if we have a functional adenoma and we suddenly have an overproduction of one of those things, insulinoma, that's a adenoma of the insulin producing cells. Way too much insulin, we get hypoglycemia. Way too much glucagon, we get way too much glucose in the blood. So think about the base process and then what those symptoms would look like. Parathyroid adenoma, we'll talk about those parathyroid, hyperparathyroidism down the road. Parathyroid adenoma is often linked also to a Brown's tumor, a benign bony lesion that occurs when there's too much parathyroid hormone. Again, we'll see that a little bit later. Pituitary adenoma, one of the most commonly asked ones because there are so many conditions that are controlled by the hypothalamus and the pituitary gland. The one thing that can pop up consistently on boards is that anytime we have a pituitary tumor, it can press on the optic chiasm if it gets too big, squishes that, and that can cause blindness. That's why anytime we have an issue with the pituitary tumor, we want to make sure we get it taken care of quickly, because if our patient goes blind, that is definitely a big, big thing. Thyroid adenoma, too much thyroid tissue can cause hyperthyroidism. Carcinomas, these are some of our malignant guys. Adenocarcinoma, again, this is glandular epithelium, adeno being the glandular. One of the most common ones being in the lung, the lung adenocarcinoma, most commonly from smoking. I'm going to skip a couple of these. Cervical carcinoma, the most commonly asked question about cervical carcinoma is that it is linked to the human papillomavirus 16 and 18. Very, very commonly associated with those. Microbiology likes to ask this specific question in part of its question pool. Colorectal adenocarcinoma. This is the most common form of colon cancer, most commonly found in the US, as well as some parts of Japan, actually, wherever you have lots and lots of smoked foods. The smoked foods has a carcinogenic effect in the colon. Esophageal adenocarcinoma. This has an association with Barrett's esophagus as well as GERD. We already mentioned Barrett's esophagus and GERD a little bit above when we talked about metaplasia, dysplasia, and anaplasia and how the cells can change. A really good question. This is Barrett's esophagus and the esophageal adenocarcinoma, very, very commonly asked on boards because GERD is a very, very prominent condition. So we want to make sure that as chiropractors, as primary care providers, we know that what's going on with these things and what can potentially happen. So potential question you could get asked is Barrett's esophagus or chronic GERD can result in which of the following? And the answer choice would be an esophageal adenocarcinoma. Hepatocellular carcinoma. This is a malignant tumor of the hepatocytes, that's the liver, the most common primary liver cancer, commonly linked to chronic hepatitis, specifically types B and C. Later on, I have a little chunk that talks about hepatitis. Hepatitis is more commonly asked in the microbiology chunk of material, so it will be pooled with the pathology in the second half of the exam. So expect probably one question somewhat linked to hepatitis of some kind. Another one, prostate, anything that has to do with the prostate cancer, we want to remember this specific word, Batson's venous plexus. The Batson's venous plexus, it's through this blood system that prostate cancer can metastasize to the low back. We think, what kind of person, what kind of patient would we expect this to be? This is going to be an older guy who's having low back pain. It's waking him up, especially at night. He has a deep, boring bone type pain potentially. He is losing weight without trying. He might have a fever. All of those kind of conditions, all of those stuff put together. Additionally, he might have trouble going to the bathroom. He might have some urinary incontinence. All of those together, we think, oh, potential metastasis through the Batson's venous plexus from the prostate. Another one that gets very commonly asked, small cell carcinoma, aka oat cell carcinoma. This one is one of the most common conditions found, one of the most common cancers in the lung. It's associated with smoking, has a very poor prognosis. Oftentimes, because it is caught super late, it's typically already working in stage 3, potentially stage 4, before they really find something like this. It can produce what are called paraneoplastic syndrome. Tumors have a funny way of giving off extra chemicals, extra things, extra bits and proteins and stuff that can wreak havoc in other parts of the body. Most commonly, the question that got asked, it's associated with Cushing's. Oat cell carcinoma can actually give off a hormone very similar to the adrenal gland stimulating hormone, specifically for cortisol. So the adrenocorticotropic hormone, so it stimulates and it causes the body to release more cortisol. That's very commonly asked as a test question. Squamous cell carcinoma, this is associated with osteomyelitis and a cloaca. We'll talk about that a little bit further down when we see kind of what a cloaca is. Fibromas, we have the fibroadenoma of the breast. This is a repeat. Uterine leiomyoma, aka uterine fibroids. Leiomyoma, that is a smooth muscle tumor. This is most commonly an incidental finding on an x-ray, typically of an older person, of an older female who's already post-menopause, and you'll see in kind of the pelvic cavity, pelvic brim, you'll see just this big kind of oddly shaped glob of calcified material. A lot of the times, it's never really, like, it causes a lot of pain while it's growing, while they're having issues. Unfortunately, women's health is often disregarded. And so often women who might be having this pain, it gets written off just as really bad period cramps or something else and doesn't really ever get looked into. And so you end up with a lot of women who have this as an incidental finding in their pelvis. So do better. As medical professionals, it is our job to make sure that we take those situations seriously. Non-ossifying fibroma, we'll look at that again a little bit when we talk about the bone stuff. Now, lymphomas, we have Burkitt's lymphoma and we have Hodgkin's lymphoma. You probably have almost never heard of Burkitt's lymphoma. The only connection that we really need to know about it is that it's associated with the Epstein-Barr virus infection and that it's endemic in Central Africa. This is more of a microbiology type question that it could pop up. Unlikely to pop up, but it definitely could. Additionally, when we talk about Hodgkin's lymphoma, the most important thing that we want to understand is that it's associated with Reed-Sternberg cells. Reed-Sternberg cells, this is the definitive diagnosis for Hodgkin's lymphoma. Every other cancer that is out there, if it does not, every other cancer of the lymphatic system, if it does not have Reed-Sternberg cells, it is non-Hodgkin's lymphoma. So you have two groups, Hodgkin's lymphoma, non-Hodgkin's lymphoma, that's it. Sarcomas, chondrosarcoma and Ewing sarcoma we'll review in the bone tumors. Fibrosarcoma, uncommonly asked, a little bit more part 2, part 3, and we'll see that later. Kaposi sarcoma, this one is almost always asked in the pathology portion, or as well micro, can come from there as well. It is the most common cancer in AIDS or HIV patients. I had this on, I think, 2 or 3 of my board exams, specifically mentioned the Kaposi sarcoma. So that's just word recognition. Make sure you know the Kaposi sarcoma is associated with AIDS. Leiomyosarcoma, Leo smooth, myomuscle, sarcoma, malignant tumor of the connective tissue in the uterus. Osteosarcoma, we'll see that again in the malignant bone tumors. Rhabdomyosarcoma. Rhabdo is specific for striated or skeletal striated muscle, so skeletal and cardiac muscle. Myomuscle sarcoma, the malignant tumor. Some of the miscellaneous ones, leukoplakia, this will pop up here and there. Leukoplakia is a white thickened patch develops on the mucous membrane. Specifically, it cannot be wiped off. That is what we want to make sure we understand. Leukoplakia cannot be wiped off. There is another condition that sounds very similar. I don't recall if it's specific on part 1. If it is, we will see it later. But it sounds similar to leukoplakia. It's also found in the mouth, but that can be wiped off. I don't remember the specific name for it right now, but it's a type of yeast infection in the mouth. But leukoplakia is cancer. You cannot scrape it or wipe it off. Morton's neuroma, most commonly between the metatarsal heads of the 3rd and the 4th toes. Often from wearing too tight of shoes. You test for it by squeezing the ball of the foot, and it causes pain. Myxoma, this is a benign tumor of connective tissue found in the heart, primarily in the left atrium. Stomach cancer, I had this question actually on my board exam. It's most common in the lesser curvature. Lesser curvature is up on the top portion of the stomach. So we have, it comes down into the stomach. The esophagus comes down into the stomach. We have the lesser curvature up top, the greater curvature all the way down on the bottom. Teratoma, this is a tumor of all 3 germinal layers. It has a bunch of tissues inside of it. If you get any type of question that's talking about a lump of whatever, a lump or a tumor that has teeth, hair, skin, other junk all inside of it, that is a teratoma. Virchow's node, you almost always get a question about Virchow's node as well. They like to ask about the Virchow's node. This is where we have when we have stomach cancer or some type of cancer of the GI tract, you end up getting a lymph node that gets cancer in it right here on the left side, just above the clavicle. That is because our lymphatic system from the whole GI tract goes up and drains right by the left clavicle into the left subclavian vein. So any type of metastasis from the gut is going to end up right there first. And again, we will look at a bunch more of the tumors and everything specifically to the bone under the bones section, bones and cartilage under the bones section. So that is all that we have for the neoplasia, and we will keep on moving along.